All right, so all right, causes and explanations. So, like like the previous chapter for depression, it has also different perspective, different approaches towards why schizophrenia happens. The first aspect is the biological causes, or more specifically, biochemical explanations for schizophrenia, as in, are there any neurotransmitters at play? Well, in depression, it was serotonin. In schizophrenia, it's gonna be dopamine. So, the entire thing that we're going to discuss right now is cumulatively or collectively known as dopamine hypothesis, and there are different explanations to it. So what you're going to do in CIE, you're not going to explain them, or you're not going to take them as separate causes. You're going to take everything that we're going to discuss in this section at one single cause, and you're going to collectively call them the dopamine hypothesis. So inside dopamine hypothesis, we have four different explanations, or four or five different explanations. See, dopamine occurs in the brain because of neurotransmitter. So there's either two possible outcomes why schizophrenia happens. Either the dopamine that you have, the neurochemical, there's something wrong with the neurochemical. Could be that the neurochemical itself may be in lower amount than usual, or maybe in excess amount than usual, so the levels might not be adequate. So there's one aspect. The other aspect could be that the neurotransmitters are at their normal level, right? But the receptors where they attach, where they attach to get transported to other neurons, other areas, maybe those receptors are inadequate. Maybe those receptors may be more in number, maybe less in number. So it's either the dopamine's fault or it's either the receptor's fault. So let's look at that. So first of all, we have research by Lindstrom, right? And basically he assesses this dopamine hypothesis indirectly. He doesn't do it on schizophrenic people, he kind of does it indirectly. So he chooses to perform something on Parkinson people. So people with Parkinson, right? People with Parkinson, I don't know if you have seen those people. They exhibit physical symptoms such as tremors. Their hands shake, their lips kind of quiver, and so they're in tremor, they're shaking because of the condition. So that's Parkinson. And what happens in Parkinson is a understood fact that in Parkinson your dopamine level drops way down, right? So you have a lack of dopamine, that's why you develop Parkinson. That's understood. So what Lindstrom is doing right here is, in 1999, he's giving people Parkinson medicine that is known as levodopa. That's L-dopa written here, right? You don't need to remember that. Just remember that he gives people something to get better. So levodopa is usually given in Parkinson's, so that when people take it, their dopamine level rises up. Because in Parkinson you have less lack of dopamine, so you need dopamine. Levodopa does that job. But what happens is, what if your dopamine level, right? Imagine this: instead of like coming to a normal, it crosses normal and exceeds towards like abnormal levels. What happens if your dopamine shoots up to an abnormal level? So he found out that when Parkinson people, when they're given levodopa, right, and when sometimes levodopa causes their dopamine to shoot way up, the Parkinson people develop symptoms of hallucination, positive symptoms, right? Sometimes delusion. And this is why Lindstrom then concluded that, you know what? Schizophrenia may be caused by an excess in dopamine. Parkinson is caused by lack in dopamine. Schizophrenia is caused by excess in dopamine. Even though he did this on Parkinson people, right? Generalizability may be a factor, representation may be a factor, but that's one theory to go by. And you usually find this in people who take cocaine, and cocaine and drugs is known to cause your dopamine to shoot up, because dopamine is a pleasure hormone. Whenever you get pleasure, your dopamine shoots up. So people who take cocaine, they experience pleasure, hallucination. uh they are, but they are they're not the main symptoms, right? They could be accompanied into other disorders, but they're not the main symptoms. Sometimes in bipolar disorder, when you have mania, severe mania, you could have hallucination, right? But we would not count hallucination as a symptoms. So because along with hallucination, you have other major symptoms as well, right? So basically, along with schizophrenia, there are other major symptoms as well, such as delusions, right? Disorganized speech. So in bipolar disorder, right, you may have hallucination, uh, but you have other manic symptoms accompanying with that. It's not hallucination alone. So like you have to see what occurs with hallucination. So that's why uh, it could be possible that the positive symptoms these people are feeling, right? One of them could be hallucination, and another could be delusions or disorganized speech. So we're not clear on that. That's why he may have associated that with schizophrenia rather than leaving it hallucination as in general. So there might have been other symptoms, specifically positive symptoms that have been showing characteristics of schizophrenia. That's why Lindstrom kind of like may have made connection to schizophrenia. So that's one aspect. So the neurotransmitter could be in excess. That's his version. So there's another version, right? And this is by Wise. Now Wise goes for something else. He conducts a post-mortem of people who have schizophrenia and have died. So what he does is he like cuts open people's brain who have schizophrenia and died, and he finds out that you know what, dopamine. I don't know about it, but there's receptors over here that I can study. So he found out that people who have schizophrenia, they have higher number of receptors than usual as compared to normal people. So the receptors we're going to talk about is specifically known as the D2 receptors. So the D2 receptors are in excess in schizophrenic people than normal people, which may kind of explain why people have increased dopamine activity because more receptors, more neurotransmitter activity, which may lead a person to develop schizophrenic symptoms. So that's one aspect. Secondly, right? So now it's like we have two like possible causes. Like it's either a neurotransmitter or it's either a receptor. Now let's go move on. So Nestler does an experiment or does a study using PET scan, right? Brain scans. So he wants to study which area of the brain is active in schizophrenia, and what symptoms do those active brain parts highlight in a person who has schizophrenia. So, for example, if your frontal lobe is active, what symptoms schizophrenia would you show? So over here, we're finding out two things: what area is active, and which symptoms are you going to show? So he does this through a PET scan, and he finds two things: the limbic cortex, right? Uh, the limbic system, right, specifically has a large number of receptors. So over there, you're gonna have increased dopamine activities. So that's gonna lead to positive symptoms. So limbic system has large number of receptors, leads to positive symptoms. And in your prefrontal cortex, right, the dopamine activity is decreased now. So there's another area in the brain that's prefrontal cortex, right? And over there, dopamine activity will decrease, so that's going to lead to negative symptoms. So Nestor kind of explains why do you have positive symptoms. Positive symptoms happen because of increased dopamine activity, and negative symptoms happen because of decreased dopamine activity. Other people like Lindstrom and Weiss don't do that. They kind of explain why positive symptoms happen, but Nestor kind of explains why negative symptoms happen as well. So like Nestor is kind of advantageous in that regard. Moving on. So last study is by Lindstrom as well, but this Lindstrom is different because he has an E in the name, and this person has no E in the name, right? So they're both Lindstroms, both did this study in 1999, but this one is different, so you shouldn't mix up the both. So he did this study in schizophrenia people, a control group. So what he did was, right, uh, he has an idea. People who don't have schizophrenia will not have excess receptors, right? Won't have increased D2 receptors. People with schizophrenia are going to have increased D2 receptors, right? Now think of receptors as doors and think of dopamine as people. Would it be correct to say that the level of dopamine is not constant, for example, constantly high or constantly low? Uh, yes, it could be the case that sometimes people might have ups and downs of dopamine, right? But Nestle kind of like experience in a way that it is localized to a certain area as well. So he does not only explain the level of dopamine that is needed to have that symptom. He also tells us which area should have high dopamine for positive symptoms and which area should have low dopamine for negative symptoms. So he kinds of like specifies the area as well. But yes, the dopamine levels may go up and down in people who have schizophrenia, so it's not always constant. All right. So this guy, the basic idea is people who are schizophrenia are going to have increased D2 receptors. People who are not schizophrenic are not going to have increased D2 receptors. Think of D2 receptors as door and think of dopamine as people. The more doors you have, the more people can pass through in a specific time frame. So imagine two rooms. One room has one door for 100 people and one room has four doors for 100 people. The four-door room is going to get quickly empty than the room that has one door. So to test this hypothesis, what he does is he gives he gives both of the group levodopa. Levodopa is a drug to kind of increase the level of dopamine in your brain. So he's giving them dopamine, both of them, and he wants to see whose brain will kind of quickly absorb dopamine. Is it going to be the schizophrenics or is it going to be the control? So using a PET scan, he finds out that people who have schizophrenia absorb levodopa quicker because they have more receptors. So this guy Lindstrom goes on to conclude that schizophrenia is caused by increased D2 receptors, as proven through the experiment. Nessler uses a brain scan to find out that dopamine activity is responsible for the schizophrenia. Weiss goes with D2 receptors, and Lindstrom goes on with increased dopamine itself. So there's two things: it's either dopamine or it's either a receptor. So again, as I said, even though there are kind of like four or three explanations of why schizophrenia happens, but you're gonna collectively call them the dopamine hypothesis, right? And you don't have to explain why he said this or Lindstrom said this. You can use these as supporting evidences of biological cause of schizophrenia, but the way you're going to refer to this is collectively say that dopamine is either caused by an increased level of dopamine activity because of excess dopamine, or it may be caused by excess receptors in the brain known as D2 receptors. Hence, both of these causes are possible and has not been confirmed, and has it is hence known as the dopamine hypothesis. So you're going to tell them collectively. You won't kind of highlight every single experiment because CIE doesn't require you to do that. In evaluation, you can, for example, this might lack in generalizability. Uh, this might kind of like maybe more valid. Uh, he uses PET scan. It's also applicable in the sense he experienced both symptoms. Uh, he uses a control group, so it's more valid. PET scan is more valid. So like you can use these studies individually as an evaluation, but summary wise, not so much. So evaluation wise, all of them are nature, obviously, because be either it's dopamine or either it's the D2 receptors. They are both occur naturally. They are both natural phenomena. They were biological phenomena. So it's the nature side of the debate, not nurture. Individual completely because it's up to the individual's dopamine level or it's up to the individual's dopamine D2 receptors. There's no situation at play. It's deterministic because you cannot control your dopamine or you cannot control your receptors actively. It's passive, it's not in your control, right? And what reductionist, completely reductionist because it's either going to be the dopamine or it's either going to be the receptor. You're not looking at any other neurotransmitter, you're not looking at any other situational causes, cognitive causes. So it's completely reductionist. It's more scientific than any other explanation we're going to study because number one, it uses PET scans. Number two, dopamine and D2 receptors can actually be scientifically studied, and there is evidence for it. Other explanations, you're going to find out that there's no specific evidence for it, so it's more scientific, hence it's more valid, hence it's more reliable, because you can then standardize how these experiments were conducted. Other theories, not so much. You can also say it's more is generalizable, because regardless of what country we do this research on, a person's biology may be unchanged according to culture. So whoever brains you study, right, they might behave in the same way regardless of what the culture is. So you can say there's no impact of culture bias. uh, and if everyone's biology is the same, it's more generalizable as well as compared to any other explanation. So this is a good area for evaluation, because you're going to get so many points and so easy to frame those points, because uh, this explanation kind of fits in all the bracket. So you guys have any questions for the dopamine hypothesis, or it's all clear? All right. So now that you're done with the dopamine hypothesis, see this section, because it has to do with dopamine, is known as the biochemical. Yeah, I can say it biological, but I'm going to specify it biochemical, because there's two biological explanations over here. The second is genetics. So that's why, to separate genetics, I'm going to refer to the dopamine hypothesis as biochemical. And it's genetics. See, so there's so many studies over here. The one that you're going to be focusing on is Garsman and Shields, the one that is highlighted in yellow. So, is there any genetic connection of schizophrenia? Can genetic influence schizophrenia? So basically, the idea is there's two type of twins, right? There's monozygotic twins and there's dizygotic twins. For people who did not study biology, it's like this. See, uh, if you kind of like when you like when it's if you come out from one cell, like if this one cell, right, divides it into two and makes identical copies like this, right? There's two identical copies of the cell now. So because you came from one cell known as zygote, you're gonna be known as a monozygotic twin. So like think of twins that have same features, identical twins, identical, identical twins who have the same copy of your genetic information. So like 100% same genetic material is known as monozygotic twins. And there's also different type of twins known as dizygotic twins. Dizygotic twins don't share 100% genetic information. They share 50% of the genetic information, even though they are born at the same time. Yeah, that's why you call them twins. But they don't share 100% genetic information. They share 50% genetic information. So they might they're not identical in some ways. Monozygotic things are identical in some ways. They share 100% genetic information. And the idea is basically uh, which pair of twins will schizophrenia occur the most? Will it occur in monozygotic twins, or will it occur more in dizygotic twins? See, we're studying genetic approach. So the more see if the results come as this, if we study 10 monozygotic twins and 10 out of 10 monozygotic twins gives out schizophrenia, it means that genetic does play a role. So the results were kind of different. So they studied 24. See, 24 monozygotic twins. Out of 24, 10 had schizophrenia, as in if one twin will have schizophrenia, the other twin will have schizophrenia. So out of 24 instances, this happened only 10 times. Percentage wise is 42. But what about dizygotic twins? They studied 33 pairs of dizygotic twins, and if one dizygotic twin had schizophrenia, how many times would the other one have? Three. So over here you can see the clear difference that if there's more genetic information similar in the twins, there are more chances that the other twin will develop schizophrenia. So this kind of supports the genetic hypothesis, because monozygotic twins 100% genetic information same. If this has schizophrenia, they will also develops schizophrenia means genetic linkage. But the thing is, it's not 24 out of 24, it's 10 out of 24. So what's going on here? If it was genetic, right? Would Shouldn't this be 24 out of 24? So it's not the case. It is genetic because we have some results coming out of it, but it's not completely genetic. So it's like could be nurture as well. So I don't know what happened. Like when they upgraded your syllabus, right? I remember when I was studying A levels 9698. I don't exactly remember what, but there was this specific theory about, or there was a specific study that you can find out on the internet if you have free time, that they kind of studied monozygotic twins who like lived together at birth, but then when they grew up, right, they went to separate families. They were adopted. One goes to another family, one goes to another family. And it turns out that one of the monozygote twins develops schizophrenia, and the other monozygote twin does not develop schizophrenia. And they kind of said that the family where the twin was sent also plays an impact, because like different families have like different reactions to you. So like you get more stress in more family, you may develop schizophrenia, especially if you have a gene. The other twin went to a good family, so even though he had a gene for schizophrenia, he wasn't as stressed out, so like he didn't have schizophrenia. I don't know which study was that, but I had this in my previous syllabus. So that study supports the nurture side of the debate as well. So it's nature nurture both in that regard. If you don't want to go for that study, if you don't want to look up that study, that's fine. You still can pull off the nature nurture debate, because it's nurture, because in the result is 10 out of 24. So 10 uh, highlights the nature part, but the missing 14 highlights the nurture, because it's not 100% genetic information. There seems to be something else at play. And it's not only, I have a question. What is that? So like, can you be a carrier but not develop the disease? Yes, that's what they were saying, kind of, yeah. But but you won't use the word carrier and you won't use the word disease, because that's medical term. So in psychology you're going to use, uh, you can be a person who may have the tendency but not develop the disorder. So like carrier, instead of carrier you use the word tendency. All right. So the all right. So there's see this result that Gossman and Shield got, right. There were many studies done this with this specific thing in mind, and every single study you see, no study has gotten 100% result. It's either mixed 60 70, 60 70, 50 30. So the findings that the Gottman Shield got are kind of supported by all the other genetic study that were done. So what does it mean? Number one, nature nurture sideline, number one. Number two, the study has reliable results, right? Because if you get the same results over and over again, the study is reliable. So using other studies as evidence, it is reliable. So it's reliable. Number two, it's valid because like you cannot influence genetics. It's objective. It's scientific. Number three, is it individual situational as individual in terms of the person genetic, but situational if you can find out the study that I was referring to. So that would come out as a situational variable. Reductionist, completely reductionist, because they're attributing genetic to the cause of schizophrenia. They aren't doing anything else. Even though the results highlight nature nurture, they said nothing about that. They said that genetic causes schizophrenia. So that's why it's reductionist. They do not look at any other perspective. Uh, is deterministic because you cannot influence your genetics. It's out of your hand. Um, what else? Is it culture bias? Well, if you look at this table, right, it's been done in many different countries. So you may argue that's not culture bias because, like, but you may argue as well that, these studies were outdated. It's 2020, so it might be less representative of the times that we live. So it might not be generalizable to the population that we have now, because these studies were conducted way before, outdated. Anyways, so is there any confusion in Gottman Shield, or is everything clear? And this is what the summary means. They haven't given percentages, right? They haven't given figures, but if you wanna be specific about numbers, you can give numbers over here. All right, so whenever you're practicing for exams, right, like when you're doing past papers and stuff, or when you feel like you know what you're studying, but you can't kind of put it into words, so like comparing your answer to the marking scheme answer would be a good step to a good way to do that. Not 100%, not 100%, but I would advise you to do that for paper 3 and paper 4 section A. Paper 3 and paper 4 section A, like if you compare your answer with the marking scheme, is gonna give you a good idea where you stand regarding the understanding of the concept. And this also kind of gives you the understanding of what the examiner kind of expects from you, how much information you're supposed to give, how much information you're not supposed to give. So even though we're studying in depth, and we're studying in depth so that you can solve the paper 4 section C debate question if they ask whether genetic approach is deterministic or not, etc., etc. That's why we're going in depth. But in reality, this is what CIE people require from you, right? Just a basic short summary, if nothing else. This is much more detailed version, so you can see also this is a good idea to see what's the difference between 2 mark question, what's the difference between 4 mark question, even though the question means the same thing. So over here, right, you are supposed to give more details, so that's why you have more marks. So that's why over here you can see they use numerical percentages, right? So it gives you a good idea that like numerical percentages are used sometimes. The numerical percentages or the dates or the number of sample is not 100% accurate in marking scheme. So you might face a little discrepancy in percentages or the number of people that were recruited, because sometimes CIE does that. But other than that, this gives you a clear idea of how you're supposed to attempt the 4 mark question and the 2 mark question if you get to be asked about the same thing. All right. So this is also part in your syllabus, right? So this is also a genetic explanation of schizophrenia. Is still in genetic, right? Because we're talking about monozygotic twins. So they also did like this study about correlation, that the more severe the symptoms are of one twin, the more chances that the other twin will have to develop schizophrenia. So if one twin is moderately schizophrenic, the other twin will have less chance of developing schizophrenia as compared to having a severe uh, twin with severe schizophrenia. So this table gives you that idea. For example, if the twin is like catatonic, catatonic as in catatonic is like severe schizophrenia. So if the twin has catatonia, and if the twin is diagnosed as mild schizophrenia, so there's a 33% that the other twin will be diagnosed as mild schizophrenia. But if it's severe catatonia, 91% chance that the other twin will develop severe catatonia as well. So this table also gives you a summary of genetic connection to schizophrenia. Yes, but in relation with severity. All right. So yeah, that's it. This evaluation, by the way, in 29 is the is about Gottman Shield, where they kind of how they carry out the result. They kind of find out the concordance, or they find out the genetic presence of schizophrenia by conducting interviews, right? And if you want to find out interviews, etc., you need to interview the parents as well and patients as well. So patients did go under cognitive tests to ensure that whatever their diagnosis schizophrenia was valid, and the tests were scored by independent judges. Independent judges, if you want to know, are people who work separately but rate the same thing. So like it's like inter-rated reliability. So Gaussian shield result, even though like it doesn't highlight anything that anything science special, but the way they got the result was in depth. They kind of called every kid in. They conducted assessments on it using a valid test, so that the diagnosis of schizophrenia is valid. Integrated reliability was there, and they conducted interview from the twin and patients as well as the parents of people. All right. One weakness is that, see, there are different bunch of studies over here, right? A table. Even though I said that the study is supported by other researchers, but see, we're using, all right, the book we use to diagnose people is known as DSM-5, right? You know that. And 5 means that there has been one, two, three, four, 5. So there have been 4 previous versions as well. So DSM-5, I forgot, maybe it was introduced to 2010, right? Or 2012. Before that, we had DSM-4 TR. You may have heard the name when you did your AS study about button phobia, that he was diagnosed using DSM-4 TR. Before 4 TR, we had 4. So even though these studies support every single studies, but see, could be that in 1963 there have been another version of DSM, in 1967 another version of DSM, 1998 another version of DSM. So as DSM changes, the criteria of schizophrenia also changes. So for example, in 1953, what was schizophrenia might have been different to what is schizophrenia in 1998. So the criteria differs. So that's why we might take these results as with some sort of doubt, because the diagnostic criteria for every single era was different for schizophrenia, and that's why we're not sure if people who are schizophrenic then would be classified as schizophrenic now. So that's the problem we have with their study. Is everything clear so far? All right, what about all right. All right, so now we're coming on to, wait, I have a question. What is that question? All right, no question. So now we're coming on to the last explanation of schizophrenia. Why does schizophrenia happen? So like this, every single thing that you studied right now is scientific, is objective. So now you're gonna get to know what does subjectively feel like. Once you know what's objective, it's a good way to feel what does subjectively feel like. So it's a good idea to kind of understand that, because let's suppose we study anxiety or like phobia or impulse control disorders, you might struggle to find subjectivity within theories. You don't know what's a subjective theory, you don't know what's an objective theory. So this is a good way to highlight what the subjective theory is, because everything we discussed right now, the dopamine hypothesis, objective, the genetic, objective, this is subjective. The cognitive explanation of schizophrenia given by Frith. uh, in your book, the Black Book, right? The Julia Russell book. The way it is written is kind of jumbled up for me, because I really had a hard time understanding it. So like I used the Oxford book as help as well, to kind of like get a clear idea of what's happening here. All right. So Frith says that we have these systems, right? And they're part of our cognition. They're not part of our brain, they're part of our cognition. They help us to carry out cognitive tasks, thinking, feeling, understanding, etc. So there are 3 things inside of cognition, right? And basically, they all serve each purpose. Meta representation system, right? Is responsible for understanding other people's feeling, other people's thoughts, and your feelings and your thoughts. So, like kind of like empathy, but we're not going to use the word empathy. Don't use the word empathy. Meta representation system is responsible for this. Supervisory attentive system. Supervisory attention system is responsible to make you do things yourself. If you're thirsty, you're gonna get up and get a glass of water yourself. If you are in pain, you are gonna ask for help yourself. So supervisory attention attentive system makes you do things yourself. Central monitoring system. The central monitoring system, what does is it tells you what thing happened from you and what thing did not happen from you. As in, It tells you, like, let's suppose you knock a glass over and you heard the sound of it smashing onto the ground. So it'll tell you that you caused the glass to fall and smash onto the ground. It's going to tell you what things you are responsible for and what things you were not responsible for. Like, if you kind of hear thoughts in your head, if you think something, right, you think your thoughts in some voice. It could be a male voice, it could be a female voice, it could be your own voice. When you're talking to yourself, you think things in your head, right, and you do it in a voice. So it tells you that the voices you are hearing in your head right now are not hallucinations. It is basically your thoughts that you're thinking to yourself. So it tells you what is from you, what things you are doing right now, and what things you are not doing right now. So that is what is responsible for giving you feedback of the things that you're doing and not doing. All right. So Fritz says that this is how the normal person should function. If there's problems in any one of this, you're gonna have a problem regarding schizophrenia. So he first of all says that you're if you what happens if you have problems in these two. So if you have dysfunction in these two, right? You're not gonna be able to understand other people's emotions because meta representation system is damaged. You're not gonna be able to understand your own thoughts and feelings. Meta representation system damaged, and also you're not gonna be able to do things that you once used to do on your own. You won't go to the bathroom when you feel like it. You won't ask for water. You won't do things by yourself. So supervisory attention system is also damaged. What happens then? Fritz says that if these two things are damaged, this could explain why negative symptoms happen. Because people who exhibit negative symptoms, right, they withdraw, they socially withdraw, they stop speaking, and they stop showing emotions. So these are the negative symptoms, and Fritz says that it could happen if you have problems in these two areas. Think about this way. Or it doesn't happen overnight, by the way. Like one day your these things shut down and you develop this. Fritz doesn't say that. Fritz says, imagine these things have been shut down for a long amount of time. These things will develop in you. For example, if you don't understand what people's thoughts and feelings are, and you don't understand what your thoughts and feelings are, and you've been interacting with people over a long course of time, would you then feel as if you don't understand people, and hence would you kind of distance yourself from people? You could over time. You feel like you don't understand people, and then you might not feel like you want to interact. So you might develop withdrawal, and because you don't understand your emotions and other people's emotions, you may not show emotions because you don't know them, you don't understand them. And let's suppose that because you then no longer show emotions, no longer socialize, you may then start to not speak, say much things as well. So you might develop lack of speech. So, or you might develop lack of speech because you don't understand what people are saying, so you don't know what to say. So that's why you stop speaking. So, anyways, what I'm saying is this develops. It doesn't happen overnight, right? So this is nurture perspective over here. If you want clarification whether it's immediate or is gradual, this is gradual, by the way. So, Frit, if you have a problem, these two negative symptoms could occur, and this is why. But if you have a problem in this one, the central mounting system, you won't be able to differentiate between your thoughts and random voices in your head. You won't be able to differentiate whether the door closed because you closed it or did the door close on its own. You won't be able to differentiate whether you turned on the TV or did the TV turn itself on. So everything might then make you feel like you're being followed or you're hearing voices in your head. So like it might cause you to develop positive symptoms. You might feel as if you're hearing voices in your head, but it's not voices, they are actually your thoughts. Because this is damaged, you don't know these are thoughts, you think these are your voices in your head. The door closed by itself, you think you're being followed even though you closed the door by yourself. This is damaged, so you cannot tell the difference. So this could explain why positive symptoms happen in people's schizophrenia, according to Fred. So central monitoring system dysfunction, positive symptoms. The meta representation and supervisory attentive system dysfunction, negative symptoms. All right. I'm gonna talk about this in just a while, but there's something that I've left behind, which is, yeah, this table. Kind of exactly like it gives you a good idea of what each system is supposed to do, and like how the malfunction of it develops symptoms. So like if this is a good idea, yeah, this gives you a good idea to like understand this entire process. So you may look at slide number 32 if you want to later on. I'll send you the slides later on. All right. Anyways, so to prove that this theory actually works, Frith conducts an experiment. So Frith and Drone do this experiment in 1986, and basically what does is he goes to people's schizophrenia and asks them to draw fruits. You draw fruits and you name fruits. People with schizophrenia cannot do that, or they have difficulty. The reason is that, see, if you could do things on your own, right? Self initiating action, then you could draw fruits on your own, right? You could say the name of fruits on your own, but because this is damaged, you won't say things, you won't do things. Hence, this could be leading to a negative symptom, specifically lack of speech or lack of initiative. Similarly, uh, because you are so used to not interacting with people because you don't understand people's emotion, hence you're withdrawn now, hence you don't talk. So because of that, you won't be able to say the names of fruit because you have now developed lack of speech. So this again causes you to develop lack of speech indirectly, because of this you stop interacting with people, and now you don't speak anymore. So that's why you don't say names of fruits. So Frith kind of did this experiment to highlight that, see, people who have dysfunction in these two areas are not going to be able to pass this test because they have negative symptoms, because of the reason that he just explained. Uh, he did this experiment for positive symptoms as well to prove that his theory works. Uh, I'm gonna restart this meeting because it's about to end. So I'm gonna end the class, send you the link now on WhatsApp, then we're gonna resume.